fine?
Yes, yes.
Do you want me to create a paragraph for Dr. Amprakash sir also?
No, that is fine. It's okay, no problem.
Okay, okay. So now we are live on YouTube. So my suggestion is, just give me 1 second. Yeah, just give me 1 second. So I will share this YouTube. Okay. Kamal and Asta, I have made both of you co-host also. Your job will be to keep on muting people who are not supposed to be talking.
Yeah, and I have shared the link with Dr. Pallavi, YouTube live link.
Yeah, I am immediately sharing it in our group. Yeah.
So, ma'am, what you can say is in the group, please join here, if you have issues with Zoom, but then registration will not be needed for this directly.
Yeah.
So that is that. If you want, I can share the direct Zoom link also. If you
that morning, Kamal had done that. I have already mentioned it.
Kamal, what was that you shared?
The one we are on, the Zoom link.
So how did you share? So Kamal, can you check on that YouTube link I sent you on chat?
Yeah, I'll just share.
Just check and
yeah, it's saying SOGOG CME event started just now. Yeah, it's
Kamal,
live.
What was that you shared?
It's live. The same link. We are on the Zoom link.
So how did you share?
I shared it through. I copied the link.
So, yeah, Kamal, when you are viewing the just 1 second. When you're viewing the YouTube, make sure you are muted on that. Okay. If you are viewing the YouTube on the same laptop where you're viewing the Zoom, you have to mute YouTube. Otherwise, it will come again here. There'll be a multi-echo. Okay. So that's and then let me just.
That's YouTube.
Awesome. That's looking good. That's the way. So what I'll do is I'll just quickly call Dr. Amprakash sir in case he has any difficulty. He's joining in a minute. Request all of you to mute phones, especially the speakers. So they'll all join around 11, still 10 minutes more, so that should be fine.
Madam, one request, if possible, can you keep a pink ribbon over here?
Pink ribbon, where do we want?
On the sari, like it's a breast cancer awareness program.
Okay.
So all of us are in pink.
Okay.
If possible, some pink.
I have it at the back here.
Yeah.
I have it at the back. Yeah, I could have worn, I didn't know I would have worn a pink sari instead. Right, I may not have a pink ribbon ready.
Just ribbon only here, no problem.
Huh.
Small piece of paper also, pink one, it's fine.
Back it is there, ma'am. Here.
Yeah,
Full.
Niramaya,
Huh.
Niramaya.
Niramaya have it. Yeah. Maybe I can make it more focused. Okay, right. Pink word. I'm trying, ma'am. I'm trying.
Good morning, sir.
Good morning, ma'am. Good morning.
Hello, how are you?
I am fine, thank you.
Good morning, Dr. Ram.
Good morning. Good morning.
Good morning, sir.
Good morning, ma'am.
Sir, ನಾನು ಗೀತಾ
Yes.
oh, ma'am, sir.
ಗೊತ್ತಾಯ್ತು. But ಎಲ್ಲರೂ ಇವತ್ತು today is a very special day for all ladies.
Yes, sir.
Yeah.
Huh?
So, yeah, just because you guys are all involved with thermal scannings and, this was very new to me when my cousin, he first took up, he was working at Tata Cancer Hospital.
Okay.
And I was a teenager, preteen, I think at that time. And then he opted for nuclear medicine. And then I was like, Dada, what is this nuclear medicine? I mean, because that time, I mean, testing of those nuclear bombs and all those things. So it was, so I said, you are into MD medicine, then critical care, and now what you are doing with nuclear medicine, right? So he was in those initial days, first of the thing. Then he worked for Ruby Hall as HOD for PET scanning and all. And he's based in Pune now.
What's his name?
Okay.
Dr. Shrikant Solam.
I see, very good.
Yeah,
He's
my
my-
cousin. He's my
Achha.
cousin. Yeah.
Nuclear medicine is a wonderful specialty.
Yes.
One
Yeah.
that opened up all other modalities, after X-rays.
Yeah.
Uh,
So
Unfortunately, in our country, it's underused. Very much
it's
underused.
yes, very much underused. Agreed.
Ma'am,
Ram sir, we are losing audio from your side. Can we just have a recheck?
I think he's just on mute.
Yeah. Okay.
This is nowadays has become problem.
I started my thermal imaging way back in the 80s, 90s.
Yeah.
Right? And I was probably the first in India to take up this as a regular entity.
Yeah.
In fact, I was involved with mammography also to start with. And I had one of the best equipments in my own lab.
Okay.
But unfortunately, I gave up mammography because I found it to be very difficult with the patients and with the outcome that came out from mammography. So that is when I shifted over to thermal imaging. And what Geeta and her team has done, I think, is something stupendous.
Yes.
After they've tied up with me.
Yeah, that is what when Kamal had first approached me. So the basic concept, it was very easy for me to get because I was in touch with my brother all the time in those days, 15, 20 years ago. So I said something like PET scan. He said like, ha, chota PET scan. That's what Kamal told me. So I said, then yes, fine, come in and explain me the whole concept. And then I think, I just asked Dr. Geeta that we can have once in 3 months or something like that, because I think the concept is going to need a lot of a lot of education to the consultants also, right? Because it's been like mammography, it's like there, right? So if you have to displace that concept from the shelf, so there's going to be a bit of educating thing we need to do. So yeah, at least 6 months or something. I mean, we can just put down a frequency. Let us see how it works out today, because that's why I said probably if there are any questions. So let us see how it goes.
Sure. So we'll have to wait for some time, I guess, ma'am. Maybe 5-10 minutes. We'll start 5 minutes late, ma'am.
That's fine. That's fine. 5 minutes is absolutely okay.
Okay.
5-10 minutes plus minus, it's absolutely okay.
Okay, because we still are waiting for people.
Let me tell you something about mammography.
Yes,
Arrival
sir.
of mammography in India, right?
Yep.
It was way back, I think in 85, when one gynecologist from the US came to India with about 6 mammography equipments, and she wanted to popularize the concept of mammography in India. But unfortunately, there were very few takers. There were only 3 centers in India in 85 which had mammography equipment, right? And then subsequently from 85 to 2000, practically it was the early period when people gradually began to understand what mammography was all about. Because between 2000 and 2000, probably 10, that mammography went to its peak. And today we don't have mammography, we have tomography. That's a new entry into the mammography sphere. But ultrasound has transformed a lot in imaging of all other entities, including obstetrics and gynecology. I presume both of you are obstetricians.
Yeah, I'm an IVF consultant, and
Okay.
Dr. Meenakshi Patel, she's a director of multi-speciality hospital, Sunshine Global, and her special area of interest is laparoscopy, endoscopic surgeries.
You know, in 85 December, I went to Denmark to get myself oriented in endovaginal and endorectal ultrasound. I was the first with Mukund Joshi. Both of us bought the same equipment at that time. I think you have heard of Mukund Joshi, who was from
Yes,
Bombay.
yes, yes. The
He was one
rectal
of the-
probe is still required for endometriosis, diagnosing
Yes,
the deep
yes.
rectovaginal nodule.
Yes,
Yeah.
yes.
Yeah. Yeah.
So when we brought over that concept to India, 86 January, there are very few takers for it. And even,
Yeah.
right? And only after ultrasound became popular, then, the concept has today gone into the field of obstetrics.
Yeah.
Yes.
Today, a gynecologist, I think, cannot practically work without an ultrasound machine.
Yes,
That's
today.
the new stethoscope. The transvaginal
Yes,
probe
yes.
is the extension of your digits
Yes,
into
yes.
the pelvis.
Correct. In fact, in 1990, I made the same statement. I said, people are going to forget their stethoscope, and in
Yeah.
future, they're going to use only ultrasound equipment.
Yeah.
And today, practically, stethoscope is completely lost. Today, cardiology is nothing but ultrasound.
Yeah.
Obstetrics is nothing but ultrasound, right? And radiology also has become plenty of ultrasound only.
Fair.
So, ma'am, I'm keeping this as the main thing while you are speaking.
Yeah.
Is that fine? So you could also talk about the
Yeah.
agenda.
Yes. 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 Yes.
And Dr. Deepesh is going to join, or has he already joined?
He is
No, I
busy
think he's
with his work, but
he's
I will take
managing.
care of these things. Okay, no problem.
Yeah.
Or should I delete that, or is it okay?
Leave it as it is, madam. No problem.
Okay, sure. So one other thing that we announced, and Kamal would have mentioned, is
Yep.
that whoever attends this will get a free home screening of Niramai tool.
Yeah.
Hopefully, it'll be a city that we are serving because we are assuming it'll be near Ahmedabad and Vadodara. But let's see. Even otherwise, we can. If it is actually conditions apply basically. So. Yeah.
Lavi, we can start the program.
Sure. Dr. Pallavi, ma'am? You're on mute.
Meenakshi madam, in another 2 minutes we will start.
Yeah, okay.
YouTube link is already live. So I suppose
Yes.
that this basic link should also be live by then now.
And there are 7 people watching on
YouTube. Yeah.
And Dr. Palmi ma'am, can you
Yes.
announce the modality for getting the CME credits? You can.
Yeah, we have. Yeah. I will at the opening remark. I will when I just detail that what this concept is about. At that time, I will mention it has been awarded 1 ICOG and GMC credit point each.
Okay. And how to claim that? Kamal is
Yeah. That is a thing. When he will just put me with the attendance portion of all the doctors, Kamal will share me the list or the screenshot of the attendees, right? And I have to just submit it there, so we can just release the certificates.
Okay, sure. So Kamal, please take care of the screenshots and the list of participants. So all of that you take. And who will take care of the questions?
Yeah, I will be addressing the questions.
Okay.
I have asked Kamal because he will be on the participant side also. Because I've logged in on the faculty thing, I will not be able to see that side. So he'll put the screenshots on the group, or he will just put me in private, and I will then address it at the end of your talk.
Yeah, or Dr. Tanvi also can remind. We have.
Yes.
Now we can start, Pallavi.
Yes, no.
It's 11:05.
Yeah. A very good morning, everybody. Am I audible and visible? Both, right? Yeah. 8th March is celebrated at International Women's Day. So to celebrate that festival of womanhood, today we are having a CME on breast cancer screening techniques. This is a very new and innovative thing, which will be later detailed by Dr. Geeta Manjunath and also Dr. Ram Prakash sir to help out with all the queries and more detailing into the subject. He will be chairing the session. I welcome, this is a program is being held in association with SOGOG SOGOG, and we have the president, Dr. Meenakshi Ben Patel, to give the opening remarks and bless us with the president's speech. We all know Dr. Meenakshi Patel. She is the director of Sunshine Global Hospital, at present president of SOGOG, past president of Baroda Obstetric Gynae Society, and her special interest of area is endoscopic surgeries. Dr. Meenakshi Patel.
Thank you, Pallavi, for your kind words. I welcome everybody on behalf of SOGOG. As a president, it gives me immense pleasure to welcome Dr. Pallavi, President Baroda Society, Dr. Deepesh, Secretary of SOGOG, Dr. Amita, Secretary of Baroda Society, Dr. Geeta Manjunath, Founder and CEO of the Niramaya, Dr. Ram Prakash. He is a senior radiologist, first to start the thermography in India, president and secretaries of all the societies, and members of SOGOG, juniors, seniors, and respected teachers. We all are passing through a difficult time of COVID pandemic, so we have changed our learning sessions on the digital platform. Now, today, in International Women's Day, breast cancer is the second most common cancer of the female. It is the most prevalent form of the cancer, and this disease nowadays has become a major problem in the world. Due to westernization of the culture and lifestyle, the increasing number of the cases 4 times higher. One in 29 women diagnosed with a breast cancer, and in India and everywhere in the world, October is the month of breast cancer awareness month. If this cancer is not detected early, can lead to life-threatening condition. If diagnosed timely, 98% survival rate is there. Now, if you go for the WHO data in 2019, 2.09 million cases were there diagnosed, and 6,27,000 deaths globally occurred. 14% of the female cancer occurs at any age in India. It starts from early 30s to 50 to 64 years of the age. In India, the study shows that 52% of the women suffering from the cancer in Mumbai, their age group is 40 to 49 years, rate is higher in metropolitan cities. And if you consider the risk factors like family history, strongly positive mother and sister, they have a higher chances of the breast cancer. Those who have a benign breast lump, they also have a chance, dense breast tissue, unhealthy diet, unhealthy lifestyle, obesity, childhood chemotherapy taken for a long-term hormonal therapy, BRCA1 and BRCA2 genetic mutation, all these are the higher risk group patients. Another thing, in a very short, sign symptoms like small lump in the breast, discharge, discoloration of the skin tissue over the breast, ulcerations, change in the size, shape of the breast, redness and pain. This can be one of probably the sign symptoms. For all these things, prevention is better than the cure. So prevention for multidisciplinary approach for the breast cancer awareness program, screening program for the early detection. In the early detection screening program, self-examination, clinical examination, mammography, and today Dr. Manjunath and Dr. Ram Prakash will tell us other modalities for the early detection of the breast cancer. In the early detection, encourage always breastfeeding to the female, awareness of the self-examination of breast within first 5 to 7 days after the periods at the age of 20 or more than 20. If required, clinical examination is necessary. Mammography, regular healthy diet, exercise for 45 to 60 minutes, avoid unhealthy food and oily food, dietary change in the dietary habits, maintain the weight will decrease the breast cancer by 40%, and avoid busting the myths like breast cancer is a contagious, lump in the breast means carcinoma, and mammogram can cause the spread of the cancer. These myths should be broken to, and giving awareness to the public is most important on our part of the study. So now I will request Pallavi to give introduction for Dr. Geeta Manjunath, and she will take the floor.
Thank you, Dr. Thank you, Meenakshi Ben, for introducing us to the topic. I will like to introduce both our faculties, Dr. Geeta Manjunath and also Dr. Ram Prakash in detail, and then Dr. Ram can chair the session. Uh, so Dr. Geeta Manjunath is founder, CEO and CTO of Niramai. This is her brainchild. She has over 25 years of experience in IT research and has led many innovative projects in healthcare and transportation, especially catering to emerging markets. Until the end of 2016, she was lab director heading the data analytics research in Xerox India. Prior to that, she was a principal research scientist at Hewlett Packard Laboratories for about 17 years and also a member of the CDAC team, which built the first commercial supercomputer from India. I think all the people who are techno savvy and very much into softwares and gadgets, and they would understand the immense depth and the work this lady has done till now. She also holds a PhD in computer science from Indian Institute of Science Management Education from Kellogg School of Management, Chicago. She has she was also the winner of 2010 MIT Tech Review Grand Challenges for Technologies in Healthcare categories. She has also co-authored the book on cloud technologies called as Moving to the Cloud, which was published by Elsewhere's Synergisys Publications. She is a senior member of IEEE and current chair of IE Computer Science Society Bangalore. She is the inventor of 14 US patents with more pending grants. She was recently awarded the Bayrak Winner Award in 2018. And the one sentence which I would like to specifically read about is she's also on the Forbes list of self-made women for 2020. What a what a way to go for this lady. We were very much eager to hear about how you are going to help the artificial intelligence. It's always the imaging sciences, and how does this science and artificial intelligence would help the doctors and surgeons achieve the best for their patients was always very challenging and is still challenging.
Thank you very much, ma'am.
So welcome, Dr. Geeta.
Thank you very much.
Yeah, and I will just also introduce our chair for today, Dr. Ram Prakash. He was a senior residency is done in 1975. Then in post-graduation years were 1976, 79. He's at present based in Bangalore, and areas of special interest, research in digital thermal imaging, that is thermography. We'll discuss how it's going to differ from mammography, then general radiology, ultrasound and imaging. And he was amongst the innovative, amongst the first pioneers gaining knowledge for the transrectal intracavitary and high frequency ultrasound. And he's also enjoying teaching in radiology. Welcome, Dr. Ram Prakash, sir.
Thank you.
Yeah, I would request Dr. Manjunath to take the floor and start.
Thank you very much, Dr. Pallavi ma'am, for your kind introduction and detailed read up of the resume as well. And I'm also very thankful for Dr. Ramprakash sir for chairing this session and agreeing to come on a Sunday for doing so. And also Dr. Meenakshi Patel for giving such a wonderful welcome speech about, and also the different symptoms and so on, going into the details, which is so very, very important, ma'am, both Dr. Pallavi ma'am and Dr. Meenakshi ma'am. The kind of activities you're doing in SOGOG and BOGS is really, really commendable, because we really have to reach many, many women and create that awareness about how to take care of their breast health. And again, we thank with full heart from Niramai for giving us an opportunity to share some of the work that we have done in the last 4 years. Yes, the topic of today's talk would be to talk about this new breast imaging solution, which we have developed at Niramai in collaboration with our partners and mentors such as Dr. Ramprakash sir as well, where we are bringing a combination of thermal imaging and AI and trying to sort of see how this can save many, many lives. A bit about Nirama itself, just because many people here may not be aware of what this is. This is a new name. Yes, we sort of, when I was in my previous organization, working with Dr. Ramprakash sir and other doctors for innovating for the emerging world, there are several instances where, it made me feel that this is something that we have to take it on the ground and really make it possible for women to go and have the test and make the accuracy to such a level that even doctors such as all of you will be able to accept this as a good solution. And we'll talk a lot more about what solution we're talking about. But Niramai is a startup which was born purely because of this passion of making technology work for breast cancer. And Niramai in Sanskrit means being healthy. Sarve Santu Niramayaha, let everyone be healthy. That's our motto. And it also has an expansion, non-invasive risk assessment through machine artificial intelligence. So the main goal of the team is to use AI and technologies such as, these novel technologies like AI in computer science, because most of us are computer scientists here and engineers and software developers. So we want to use technology and AI to non-invasively detect health risks, right? In a very, very seamless, simple fashion. So it is scalable and affordable and accessible and really make high quality healthcare possible for everyone, whether she's in a rural area or urban area and all of these places, whichever country and so on and so forth. So the first problem, that we are attempting to solve is breast cancer. A rough view of the outline of the talk here. So first I'll give an introduction, not to necessarily to breast cancer. I think all of you are experts in knowing what is needed and the risks and so on, but I'll give an introduction to the new technique and the reason why this new technique is needed, and also the gaps in the current solutions, which makes a new technique definitely required, right? Even after 30, 40 years of established techniques such as mammography, sonomammography, MRI, and so on. Then I'll give a more bird's eye view of the new technique we call thermalytics, more from outside in perspective, user feel, and so on. Then we'll go into peeling of the onion. We go into the details of exactly what is the technical detail of what is this technique, how is it going to work, because all of you are, very, very expert doctors, and you may want to know, just because somebody says, it works, why should I believe? Tell me what is inside, why should it work? Next, we'll say, have you tested with other standard of care? Have you compared with mammography? Have you compared with ultrasound? That's a question we get asked most of the time, especially in the clinical setting and clinical forums such as this. So we will talk a little bit more detail about the clinical studies we have done and the results. Finally, nothing is possible without seeing actual examples of how this looks versus mammography and does it really give the answer. So we will go through a bunch of case studies or just example images. And finally, to make it really feasible for end user to use, it has to have a regulatory stack, right? So what are the kind of regulatory clearances we have done and got, so on and so forth. And then we conclude with some of the recognitions and other things that we have received at Niramai for this particular solution. First, a bit of the context, which most of us are aware, definitely, but it's a 684,000 women all over the globe, that are dying because of this disease. Now, that, as all of you know, that it is one of the kind of simplest curable cancers among all cancers, if I may say, because, it's a soft tissue cancer, right? And also early detection is very, very critical. And there are statistics which says that if a person is detected in stage 0 or stage 1, there can be 90% survival rate. However, if a person is detected in stage 3 or stage 4, 5-year survival can be less than 5%. That is the sort of the flipping of the negative and the positive is what is possible. I'm talking about more than 5-year survival, which is what makes it very, very important to have early detection. Like Dr. Meenakshi Patel mentioned, early detection definitely is important and prevention is definitely better than cure. And at Niramai, we say prevention is better than cure, prevention is easier than cure, and prevention is less costly than cure. So because of that reason, we have to try and prevent, if not fully prevent, at least do our early diagnosis and detection. So it's almost like prevention. And in India, it's a huge challenge because the survival rate is just about 50%. Every alternate lady detected with breast cancer is dying, and many of these is because of late detection. And so the key thing that we want to go on and on is about early detection. Now, the next question is, why is early detection not happening? Why are we losing so many women to this disease? The current tests, and we will go a little bit more about what those current tests are, and many of you are already aware of this. The current tests such as mammography or an MRI or an ultrasound is not affordable for general screening like of the population when there is no symptom, when there is no major symptom or an abnormality, but we want to do it like a screening everybody. So that is where we can do early detection. So a mammography, at least in Bangalore, costs about 3,500 to 4,000 rupees. That's not affordable for, many people. Even in urban cities, urban ladies will say, why do I have to spend that money to actually do it when I have no symptoms, right? So that is a challenge. And because the machine itself can be anywhere around 80 lakh rupees, of course, you can look at analog, refurbished, which are much lower. Many small diagnostic centers are not able to afford the machine itself. And so the accessibility gets a hit. And if you have a mammography van, that will be over 2.5 crore. And of course, somebody needs to sponsor it to actually take it to villages and so on. So the whole thing is an accessibility and affordability issue, which is similar for many other diseases. Breast cancer is just one of them, to make, what we call as high quality healthcare available for everybody, right? That is a challenge. The other one is basically, all of you are aware that mammography is an X-ray based test, and which is okay because it is one only test which is proven to reduce mortality, right? With millions of people who've gone through it. However, because it is X-ray based, the guidance is that the test can be done only once in 2 years. And there are also studies which says that if a person goes through more than 6 screenings of mammography annually or biannually also, her risk to cancer can actually double depending upon which, bracket of risk she is in. So the guideline is once in 2 years, unless she's actually high risk or is a high risk bracket age, where it can be annual. So what happens if the person gets cancer between the two, mammograms? The interval cancers are also very important. And more so, as we all know, mammography is recommended only above 45 years of age. And in India, per se, the number of women who are seen with breast cancer incidences and symptoms under 45 is many more. It's also because India is a youth heavy population, right? So the average age for breast cancer incidences in women in India is 10 years lower than what it is for countries like US or other countries, right? Because it's much younger. It's about 52 years is the average age. That means half of the people who are getting are under 50 years, which means there needs to be a test which works for women under 45 years of age. And finally, not the least, right, is also when we talk about women under 45 or even above 45, women with dense breast, we have an issue with the sensitivity of mammography. And we will talk a lot more about this part, given that it's a clinical audience. But all in all, what happens, the statistics says that out of 2 billion women who are about 25 years of age and have seen, we have seen incidences even about 25, only 10% of them are actually going through regular screening, a preventative screening. 90% of this is even global number. In India, this is 98% are not going for preventative screening. We are not saying don't go to mammogram, please go, but there are so many other reasons why people are not taking it. So please come and we need another test. And if there is one test which can address even one of these issues, then we will have more number of people. If it is affordable, more number can afford. If it is accessible, more number can go. And similarly, other issues, if we can handle, more number of people going. And just a small bit about, the experience of mammogram is something that not every lady loves. That's also another one, which is a side point here. Now, a little bit more about the breast density issue, right? Again, because it's the clinical audience. So ACR, American College of Radiology, has come up with these 4 classifications of breast density, starting from A, B, C, D. A is the fatty breast and D is the highly dense breast, right? So in between is B is slightly fat, maybe like slightly dense, and C is heterogeneously dense, and of course D is highly dense. Now, when we have fatty breasts, it is actually easy to use a mammogram, and we have the expert Dr. Ramprakash sir here who can actually validate this. It's easy to find these small microcalcifications or abnormal lumps which can be malignant. Just because there is a lump, as Dr. Meenakshi Patel said, it is not cancer. Yes, 60% of the lumps are benign, right? So even then, a radiologist can actually zoom in and then figure out in possibly composition A and composition B. But when we come to composition C and composition D, it becomes very hard to find abnormalities, because abnormalities mostly tend to be lumpy, and that gets mixed up the dense breasts. Just to see an example, here you have two breasts. First one is a 60-year-old and second is a 40-year-old. And obviously this is a dense breast, and a small lesion here probably will be detected by a radiologist, even a young radiologist or not very experienced radiologist, because this is standing out in a fatty breast. But in a dense breast, where the whole breast tissue is dense because of fibroglandular nature of the breast itself, having even a bigger lesion is getting unnoticed because there's a confusion. It looks like the rest of the tissue. So that is one of the reasons why mammography is not recommended for women with dense breasts. And definitely most women under 45 have dense tissue, and they're not recommended. And unfortunately, dense breast also happens to be high risk for cancer, which means it's a dual problem, right? She's high risk and you need screening, but then mammography cannot be used. And in fact, this is not a problem that Geeta is saying because Niramai has a solution for dense breast. It is something the world is calling out. In US alone, there has been a huge momentum in the last 2 to 3 years where many of these states, 38 states, have ruled ruling on mammography reporting, saying that every mammography report should have the density, overall density of the breast. And if the density is C or D, she needs another test. And that is part of the report. The lady needs to know whether she has a dense breast or not. And there is a huge need for this new test. And there's no standard new test today to take care of the dense breast. And people may say, yes, of course, I have sonomammography. The ultrasound, breast ultrasound is a good one. Yes, and it is being offered in many, many diagnostic centers as a test for dense breast or younger women as well. If there is an abnormality like a lump or some other issue, yes, breast ultrasound can be used to actually figure out whether there are hypoechoic mass, whether there's an irregularity there, and then say whether there is a possible abnormality. And of course, you can also do, USG guided biopsy to find the final conclusion. However, ultrasound is mostly a correlation modality. When a mammogram finds a lump or a clinical breast examination finds a lump, then you can go for a sonomammogram. If there is no lump, or if it is completely asymptomatic, the screening population, trying to do an ultrasound takes a lot of time in both the breasts, and it also requires a lot of skill to find even small abnormalities when there is no symptom. So this means there is a lot of subjectivity. Very, very proficient radiologists or sonographers are able to find, but otherwise it gets unnoticed. So if there is a way to say here could be a problem, ultrasound is an excellent tool to say whether that problem is really benign or malignant. Of course, finally, you need a biopsy, to final confirmatory diagnosis before treating. Of course, there are some efforts on automatic breast ultrasound where, there are these machines which do this compression and all that. And that's like more than 3.5 crores, only 1 or 2 exist in India alone, these kinds of machines, right? Finally, then we come to mammograms, and we talked a bit about the disadvantages, such as low sensitivity in younger women, like under 45 years of age. And also the pain, makes it a little bit uncomfortable for people to go for it. And also we talked about a potential risk for radiation. All in all, in India, for screening in large numbers, right, clinical breast examination, hand-based examination is generally the policy right now because of these reasons and also the affordability, accessibility reason. Clinical breast examination is great. It's zero cost. Of course, the radiologist or the gynecologist or a physician needs to know how to palpate it. It can also be done with self-breast examination. However, hand can only find a 2.2 centimeter or 2.5 centimeter of a lesion. Before that, it's very hard, very difficult to actually find it by hand, which means it is a TNM stage 2 or above, that is stage 3 or stage 4. So that is another problem. And finally, also as Dr. Meenakshi Patel mentioned, just because there is a lump, it's not cancer. So that is where we are bringing to table a new test. Of course, there are other methods that people are aware about, PET CT, breast MRI, and all of that, but these are only diagnostic tests. These are not done for everybody who's walking around, right? So now that is where we bring a new test, which is non-invasive, non-contact, radiation-free, affordable, accessible, and so on. And that will be the topic of today's further discussion. So the current screening test or mammography, ultrasound, and clinical breast examination, and we bring from Niramai with all our partners a new test called thermalytics, which is going to be the focus of today's talk. First, let's see the advantages. Like I said, we will go outside in. We will talk about an overview of the technique from outside as an end user. Then we go into the clinical and the technical details of it. So Niramai solution, which is thermalytics, is basically a privacy-aware early stage breast cancer detection solution or a test. First and foremost, if hand can detect 2.5 centimeters, this test should detect before. Yes, it does. Our clinical validation says we are able to detect 4 millimeters and 5 millimeters of cancer, which obviously is stage 0 or stage 1, right? And most importantly, the experience of taking the test is very, very easy. It is non-contact, non-invasive, no touch, no see, we say. There is a booth, the lady enters into the booth, and the technician is also outside. Nobody touches the person, nobody sees the person. There is no radiation, there is no pain. We say 4 no's: no touch, no see, no pain, no radiation. So these 4 no's makes it very, very interesting and likable for end users. And we've seen this, we have done many camps where only 4 or 5 of them actually register for screening to start with, because breast cancer screening, I may not have cancer. But as soon as 1 or 2 of them take it, they say it's so simple. You just go sit in front of the device like this and come out after 10 minutes, you're done. The test is done. Nobody, not even a technician, is looking at you without clothes. Not even a technician is seeing. And that experience we have extended the camp to 10 days, 2 days, many hours. All of this happened because women really love our solution for the pure experience. Of course, it has to work. And yes, it does have good accuracy on women of all age groups under 45 or above 45. We have been unfortunate to detect a 17-year-old who was cancerous with this test, and a 92-year-old walked into our camp and she was benign, a small lump, and with the bent back, and still, she really loved the test as well. And it is pretty affordable. The device itself is 1/15 the cost of a mammogram, and the screening also can be done by very simply skilled health workers or nursing staff, so which makes even your operational expenses very, very low. There is no consumable or repeated cost apart from the screening report itself that Niramai generates. And it's a very portable small screening device, which is just a 1 liter water bottle this size, and it can be established in a hospital or even put in a backpack, and you can do external studies as well, or screening camps as well. So this small is how the device itself looks. This is actually, the device itself is just a thermal camera, and we will talk more about this, but this can be bought from off the shelf, but we actually buy in bulk, and we're able to provide that for our customers. And this is a very small thermal device you would have seen in airports and other places. It's completely harmless, just measures the temperature on the chest. And this device is placed right on a tripod, and simple skilled workers like health workers can be trained to use this test. And then it is installed in 70 plus hospitals today, such as Apollo Clinic, HCG, Health Spring, and several other hospitals provide this solution. And we'll talk, if there is any question, we can do it, take it. And when you go for camps like this, we create a small makeshift booth where the lady is actually right now getting screened, and the technician or an expert can be sitting outside and actually be doing the test here. We've also, have a bus which is funded by Rotary International. This is funded for Sakra World Hospital, which is a very big hospital in Bangalore. They run these camps along with Rotary twice a week, to the outskirts of Karnataka. This is called Pink Express. The only thing that is there in this is Niramai solution. There's a small room where the Niramai solution is established, and there's a small, waiting room, and cervical screening, if required, can be done. And we've done more than 2,000 outreach camps. And also recently, because of COVID, people were not coming into the hospital, we started home screening, where our team actually goes to everybody's home. I mean, like whoever registers for screening on contact at, our niramai.com, and, provides the home screening within 25 to 30 minutes, right? So it can be established, just set up in 10 minutes and the test is done in 20 minutes. So this is what is done. Now I'll play a 30-second video of the experience of this test itself and then go into the details.
Tested the Niramai technology to me. Having heard about it, I went to get a checkup done. I was quite skeptical before I went for the test. It took me by surprise because the machines didn't touch me. It was all happening from far away. जैसे eye test होते हैं ना, दूर से बिल्कुल वैसा.
Yeah, it's a very, very simple test where the lady just sits like this in front of the device and then rotates, and that's about it. There is no other, any other incision, touch, or anything that's happening. So that is the end user view. Ma'am, shall I continue and we can take the Q&A at the end, right? Ma'am? Okay. So let's see how it works. Can I continue, ma'am?
Yes, yes. We still have time. No issues.
So how does it work? The technical details. So the basic difference between a mammogram and this solution is the method of sensing the abnormality. Mammogram uses X-rays to sense the density differences, and our solution uses thermal imaging or thermography to actually sense the abnormality in the body. Thermography has been around for a long, long time. Dr. Ramprakash sir, who is chairing the session, is a super expert in thermography. He's the first person who brought thermography to India. And this is a method which just measures the temperature variations on the chest by measuring the infrared rays which are already emitted. It's basically measuring the heat that's already emitted by our body. There is no rays that are put on the body. It's just measuring the temperature. Now with COVID, everybody is aware of infrared thermometer, right? With the non-contact thermometer is exactly like that, but it's placed 3 feet. It's a high resolution. Instead of measuring 1 point, it measures 4 lakh temperature points per person. That is the difference. And that is the key to our solution. When there is an abnormality, there is higher metabolism and higher blood flow to the lesion. And so the temperature at the place and surrounding that place starts looking little abnormal. And also we have 2 breasts. And so most people get breast cancer in one breast first, it's usually,
lymph invasions.
Bilateral is very, very rare. So that's why you can actually see a huge symmetry difference between the left and the right side, and that also gives an indication of how and whether there is an abnormality. So a thermal image is something what you're seeing here, where every temperature point, every pixel, every color point here is a temperature. For example, a white color is 37 degrees Celsius, red could be 36, yellow could be 35 degrees Celsius, some things like that. And it depends on different people have different things. And this has been used by thermographers who are trained experts like Dr. Ramprakash sir. There are more than 500 of them around the world, more in US as well, who are using this for detecting abnormalities in the body and then doing other confirmatory tests. As an adjunct modality, this is also approved as, by US FDA. However, when you talk about manual thermography, there can be interpretation errors because everyone will not have a huge expertise such as Dr. Ramprakash sir, or also, may not have time to actually understand different types of, variations and so on and so forth. And it's also subjective, like, other tests where there are lots of data involved because it's a huge cognitive overload. Think about looking at 4 lakh temperature points. And this is a color point that you're seeing. What you're seeing is just a bunch of temperatures in color. And you cannot see a light yellow versus dark yellow and all of that. So you can't even see a line in which the yellow color is and so on and so forth. So what a computer can very easily detect. So when a computer sees a 4 lakh temperature point and is able to mark the areas of high malignancies with boundaries and so on, we are able to actually characterize the temperature abnormality very, very confidently and objectively and quantitatively. And that is what is thermalytics. Thermalytics is a normal solution. I don't know what happened here. Sorry. Okay, this is how it's supposed to look, but yeah. So thermalytics is a solution where it combines the thermography, which you heard last slide, with artificial intelligence, which is a new field in computer science, which is being established in almost every domain today. Artificial intelligence or machine learning is almost like, computer trying to model how our brain works. More and more, the experts look at different images, the brain becomes more and more, experienced and better, right? That is how a data-based and a decision-making algorithm, like a machine intelligence-based algorithm, will perform. And that is what we have used. We have combined thermal imaging and machine intelligence to provide this solution. So what you saw in the last time is exactly what it is last slide. So you use a thermal imaging device, generate this thermal image, right? After that is the software which actually crunches and analyzes this 4 lakh temperature points to say, where is the likely possibility of abnormality? What is the possibility of that being malignant? What are the scores? And using the scores, you can say whether somebody is likely to need a follow-up test or not. This is what is the crux of what we have built. And this is novel. You wouldn't have heard anywhere else except from Niramai or our partners, because this is made in India and it is patented in US. There are 10 granted US patents, China patents, Singapore, India, all of them, just to show that this is definitely unique in the world, and we have received a lot of awards for it.
Yeah.
Key thing is that thermal imaging detects abnormality in tissue activity. There can be a lump which can be benign, and that will not come as positive here. So we should not get confused that everything that is positive in mammography should be positive in this. Everything that is likely to be positive in mammogram and biopsy as well has to be positive here, and we will see how much we get. And again, just to reiterate, the core innovation is that the AI algorithm over thermal imaging, because thermal imaging has been around for some time, and we don't want people to get confused that it's the old thermography. It is not just thermography. It is thermography with AI. And just to give an example, there are 4 people here, images of 4 women. The top one is normal. The next one is abnormal. And these 2 are very, very confusing. There are hot spots or high temperature points, but is it abnormal? Is it not? Here it's asymmetric also. Is it abnormal or not? That is what a machine learning tool like ours is able to confidently say by analyzing all here. We take the demography information, family cancer history, age, all of that. Asymmetry in patterns, I mentioned, we model the asymmetry in 30 different ways. And thermal distribution, how is the heat itself distributed? Focal increase in temperature versus, or the whole thing is white, or is like a center point white and all that kind of thing. We have a novel algorithm, new technique for detecting blood vessel structure from thermal image. Now, when we do this blood vessel or ductal structures, we are able to detect deep tumors which are not showing a hotspot on the skin. And then we also do analysis of the boundary structure. Are there speculations in the boundary? Just like a mammogram is analyzed with those speculations, we look at thermal speculations. And also it's longer versus taller and so on, right? Those kinds of features are also looked at for this. And then we see whether the hotspot is fed with vascularity. So several features are used in order to come up with this scoring. And these are some of the patents that have been granted. And machine learning, a bit about what is machine learning. Machine learning, as I said, is training a brain with known cases. Similar to that, in machine learning, we have training phase and a testing phase. In the training phase, we show a thermal image and say whether it's cancer or not. Show another thermal image, cancer or not. Thermal image, cancer. So this is the training set. How do we know whether it's cancer or not? We actually made every person go through thermal imaging. And the same person went through mammography, ultrasound, and biopsy if she was positive, and trained this model with the biopsy result, not mammography result, not ultrasound result. We trained with the biopsy result. So with this, what happens, the machine is now confidently saying whether it's positive or negative, because biopsy is the final confirmatory test. And once we have this classifier model built, in the prediction phase, which is happening in the hospital, in the camp, and so on, a new person comes in, the input is a thermal image. There's no need for the answer now. The label is predicted. This is a rough view of machine learning, and that is the core of the solution that we have developed. We have trained the model with end-to-end solutions with and more if in case there is a mistake and the person goes for an ultrasound and a biopsy, and if that is negative, we can feed it back and make the model more and more better and better. Over 4 years, we have improved the performance from 70% to 90% plus, and I'm going to share the results. And when I say machine learning, it's not just on the final classification or score generation. It is used in several parts of Niramai solution. For example, if a thermographer comes in and takes an image which is not good, it's not cooled well, or it's taken in a wrong view, that our machine learning models can say, no, you have taken left instead of right, you have not taken in front. So those errors will be marked, and there again we use machine learning. When you take an image, you get the whole from the neck to the stomach. We actually mark the area of breast malignancy automatically using machine learning. Like that, several machine learning, more than 10 to 12 machine learning models are being used, not just one which says yes or no. And so this is computer-aided diagnostics using artificial intelligence machine learning on thermal images, which takes these images and information of the patient and generate a report. Let's get into the report part very quickly. But before that, what's the end-to-end solution look like? The lady comes in, the thermographer who is trained, or a technician, we call it, technician who's trained by Niramai, will provide the instructions of what has to be done and so on. There's a small cooling cycle, 10 minutes of cooling by a cooler or an AC is used. We have just shown fan here for ease of view. And then she sits like this, and you saw in the video, she just turns on the stool. And our algorithm actually analyzes and generates a report. This report goes to an app we have on the mobile called Niramai Doctor. And we have experts on the panel. Dr. Ramprakash sir is one such expert, and we have a couple of other experts who actually review the images on their mobile or on their PC and then certify and sign it. And only after that, it's given to the end user. Now we go into the clinical details. There are 5 thermal views that are taken for every patient. The frontal view, the left lateral, the left oblique, right lateral, and right oblique. So in simple words, it's frontal, left 45, right 45, left 90, right 90. So basically, we actually have markings on the ground for the person to say, keep one leg in front, keep one leg in the side. And so it actually becomes easy. And the technician also can see the profile of the person, how she's sitting. And so she also gives instructions for taking the right view. I now have 3 subjects which show malignant, benign, and normal cases. And then we go into more details of these kind of subjects. So here is a subject. She is subject number 48, anonymized. It's in a very, very reputed hospital where she went through Niramai test and it said malignant. And she also went through mammography ultrasound. That also was malignant. For details are here. Ill-defined irregular mass was found in the central and upper right quadrant of the right breast. That's exactly where we have marked the tool. Niramai tool actually automatically marks the blue areas which we have seen here. It is marking the upper outer quadrant, central and upper quadrants here with malignancy. And this is a clear BI-RAD 5 category, highly suggestive of malignancy. And finally, it was also confirmed with histopathology test. Yes, so this is a case where you'll see the vascularity structures as well as the hotspot structures, which are marked automatically by the tool. And the final guidance was malignant. This is a case where, it's very confusing. You look at the thermal image, there's a lot of red and yellow. You may think, wow, there may be some problem here because she has some red. No, because when you take an image, 60% of the people will have some orange or red. Just because there is an orange and red, she is not cancerous. That is also the reason why thermography alone is not used. With AI, this can be avoided. So here what we have done a lot of analysis of these which I mentioned before, and we have said it is benign. Right? It is not a malignant region. It is thermally active, but it is benign. And you see the marking in green here instead of blue. That shows the benign. There is vascularity, but still we say benign. And you see mammography and ultrasound also said it's a benign lesion where just a cystic, multiple cysts are there in both breasts. You see some activity in both, and it's a BI-RADS 2 category. And we also said it is, we call it T-BI-RADS. We use a thermal BI-RAD, which is also T-BI-RAD 2. And what's also interesting is the cysts were found in 2 o'clock position. And that's why we have actually marked the green as well. So there may be some correlation in the system, but actually she does not require any follow-up. And a purely normal with no major activity would look like this. There's no red or yellow or whatever, and very few, vascular activity. We said it's normal, and she was a BI-RAD 1 category. Just a reminder, right? BI-RAD 1 and 2 are normal and benign, respectively, and 4 and 5 are malignant, and 3 is likely benign, and so she's usually asked for a follow-up in 6 months. So it's the same criteria we use in Nirma as well when we generate a report. We call it T-BIRAD, which is thermal BIRAD rather than just BIRAD. So we will now go into four further examples. Okay, so first I'll just show the report. So the report has 3 pages. Just to make it simpler, we put everything in one slide. So there is the first one where we take the patient details, like, postmenopausal, age of menopause, when was the last menstrual cycle, family cancer history, personal cancer history, all of that is taken. And then the right side is what is generated. We generate quantitative scores called thermobiological score, areolar score, vascular score. These scores signify abnormality if they are above 0.5. This is a 0 to 1. Any number above 0.5 start looking abnormal. If thermobiological score actually gives a thermal asymmetry-based analysis, hotspot-based analysis. Areolar score is an analysis around the nipple area because, there are thick skins, the temperature there is much lower. And so that sort of is the reason why we give a separate score. It could be a ductal issue. And so the areolar score may be high if there is a ductal issue. And then vascular score is based on vascularity analysis or ductal structure analysis. And high vascularity always mean malignancy, but we are calling it out so that, the doctor can make a call. Sometimes there is a lump and then vascularity being high, she definitely needs a follow-up, or a family cancer history being high, and so on and so forth. So this vascular score has to be taken with a pinch of salt. I mean, we have to look at other conditions like a BIRAD 3 condition, but other two being greater than 5, definitely she needs a follow-up test. And also we have generated these images in the report automatically. We mark something that is suspicious of malignancy in blue, which is not in green. And this are again marked automatically. And this is a case. In addition, we generate a final impression suggesting whether it's a T-BIRAD 1, 2, 3, 4, or 5, and also suggest a follow-up also. But that is left to the doctor. The doctor can modify those final impression basis several other clinical findings and then change the final impression. The T-BIRAD score is shown only to the doctor, not to the end user, because the doctor makes the final decision. But we give all the guidance for that. And in real-time reporting, let's say when we go for camps and so on, they cannot wait for the doctor to review and give the report. And they will not have a printer to print 3 pages. So there we do a red, yellow, green, a traffic light output. Immediately, within 15 minutes, the test is done, the report is generated, and the lady knows whether she has to stay back for another test or she can go back home. This red, yellow, green is automatically generated by a health worker. And of course, here we are slightly more towards, if a person is sounding little abnormal, we just ask her to go for a second test. We make her wait for 1 hour and then do the test once again to be so sure. And then either in this case or the previous case, if a person is found to be malignant, we do not send her for treatment or biopsy directly. If this is a screening test, if she is found to be positive by thermolytics, she needs to go for an ultrasound as a correlation. After that, a biopsy if needed, and then treatment. So this is a screening test at this stage. So there's a few more examples of these T-BIRADs. So here is a case where it's asymmetry, a lot of blue areas which we have marked, which is T-BIRADS 5 is generated by our tool with a thermobiological score of 0.9 and so on. And all of these scores are high. She's definitely BIRAD 5. And yes, she was found to be a BIRADS 5 category, even with ultrasound and mammo. This is subject 138344. It's an anonymized number. Here is another case, which is T-BIRAD 1, which is automatically generated by our tool. Vascularity is 0.1, that's fine. 0.1 thermobiological score, that's fine. And yes, it was also BIRAD category 1 with mammography. Here is a case of a lot of neoplastic kind of, high thermal activity. Again, we say T-BIRAD 5, and we also saw axillary lymph node being attacked. And recently, we've also enhanced our solution to analyze axilla. And this has been accepted even in the Global Breast Cancer Conference recently. But yeah, so this is actually also saying axillary lymph node enlargement. And then this is T-BIRADS 2, right? Where there's a benign condition like the example I showed before, and it turned out to be, again, cystic here, BIRAD 2 as well. Another case of T-BIRAD 4, where there is also, which is a lump and vascularity together. And that again, though there is this ensemble score actually is an additional score which looks at all the conditions and generates some number, like whether there is a like a symptom. If a person already mentioned lump, everything is taken care of, and there again we have found that she is positive here. And I think this person is about 65 years of age, where the cutoff is 0.35 instead of 0.5. And it was also finally put as 0.4C. You see, it is 0.4C and this is 0.4, like it's not greater than 0.5. Still, because her age is above 65, even if 0.4, we actually call her as a BI-RAD 4 category. And so she was finally also detected and confirmed malignancy. And this is another case. And I can go on and on about multiple such cases, because so far we have done 34,000 screenings and women who have gone through. Some of you may think, how does the mammogram image look for these people, right? Why did mammogram, what is the advantage of it? So here are some 3 examples of how a mammogram mass looks versus how a thermal image looks for the same person. So here is a malignant person. TB score or thermobiological score is 0.55 and ensemble score 0.83. She is, as you know, like T-bar 5, right? We have seen enough examples, and we have also done a marking in the left breast that there are this. But when you look at this mammo, it's a category C. We talked about A, B, C. It's a category C, I guess. I mean, it is, some people may say D also. But essentially, where is the problem? It's very hard to find here. But here, very easily, we've actually marked it. And this is where you have to do an ultrasound. Even if mammogram, here it was BI-RAD 0. No, inconclusive. Here's another case. It's highly dense. Mammogram is completely dense, and we don't know whether it's a problem or not. And we analyze and we say, no, there's no problem. Though everywhere it is dense, it's no problem, right? She is a benign and it's a green. So this is also confirmed benign. Here is a case, it's completely, again, dense. And is there a problem or not? It looks very similar to this in terms of the mammography. But here, it's very clearly in thermal imaging, there is a huge blob here, which cannot be ignored. And the score is 94.94. So that is the way our solution works, right? It can be used wherever there is a huge, inconclusiveness in the mammogram, or wherever there is no mammogram. You can definitely use this instead of a mammogram. If you already have a mammogram, fine, you can use that. In addition, wherever there is a doubt, you can use this. Whenever there is a person less than 45, you can use this. But if you don't have a mammogram, which many diagnostic centers don't have, this is being used. Now I just go a little bit into the clinical validation. I will take 10 more minutes. We have 12 o'clock, so we have time. So a clinical validation, clinical validation or a clinical study, requires a very systematic way of computing the accuracy of a system. I gave examples of how it's working, but then the way you should do it, and as many of you know, one is you can do a retrospective analysis or a prospective analysis. Prospective analysis requires every person to come in. She takes a thermal imaging or a Niramai test, followed by mammography, ultrasound, and biopsy. Mammographers won't know the answers of Niramai test. Niramai tests, people will not know the answers of them. It's completely blinded, and somebody else, third party, compares the result like an exam. And that's how crucial the clinical validation should be. And that's how our test has been evaluated with consent taken and so on and so forth. So the first, I just shared 2 results, and there are like 7 or 8 publications, and I'll be happy to share, some of them for people who are interested in reading this. First thing is to see whether it is better than thermogram, because if you Google on thermography, you will see a lot of mixed reactions. People will say it's good. Some people will say it's very bad because it's not accurate, all of that, because it's a subjective analysis. Different people have published different results. There are also been false clinical trials that are done. So we said, how can we compare ourselves with thermography, like manual visual inspection of thermography, right? So here we have 303 patients who went through thermal imaging, and an experienced doctor actually reviewed this. And after finding if some thermal abnormality was there, the person also did an ultrasound after that. And the same images were used by Niramai Thermolytics to see automatic BI-RAD scoring or an yes or no scoring. So here because it was a diagnostic center where we did this analysis, 29 malignancies out of 303 were found. It's about 10% malignant because people were anyway walking in. So there is a little bit of a bias on people being little abnormal. So here, you will see that in this particular study, the sensitivity, because the interpretation was done by a very good expert, you know, the sensitivity was very good, 96.5% in both the cases. However, specificity was 20% better in thermolytics. Specificity is number of false positives being reduced. Higher the specificity, lower is the false positive, right? So you'll see a 20% difference in the false positive, reduced false positives when you use a machine. So a 96, 99 is an excellent test. Anyone would say, even a doctor is, you know, cannot be 100, right? Everywhere there is a limitation. You always have another test to finally confirm. This was, of course, published in Japan, you know, in VASIT conference. We've actually had 6 more trials, you know, 6+ trials where we compare mammography with Niramide test. And one of them, which I want to stress here is, it's actually a poster, and then we have a full journal paper as well. It's a poster on 769 subjects, which was accepted in ASCO Breakthrough Summit, American Society of Clinical Oncology Breakthrough Summit, which was held in Bangkok last year, 2019, sorry. As I said, 34,000 women have gone through this test. And overall, all the publications say that we have better sensitivity than mammography in all of these tests, you know, equal or better. And then positive predictive value of over mammography, manual thermography, that is the number of false positives is much, much lower. And what's interesting is so far, we have found all the cancers wherever there is no, you know, symptom. Of course, we have found all cancers in most cases, but when there is a symptom, it becomes a diagnostic case. We are still not claiming a diagnostic modality. We are a screening modality where there's no symptom. If there is a symptom, you should definitely do our test, but maybe first time you can do another test. So that for repeat screening of symptomatic people, you can do this test alone. And so the sensitivity is 100%. We have not missed any case in an asymptomatic population, the screening population, with 93% specificity. That is very, very low false positive rate of 7% false positive rate. And you may say, how does it compare with mammography? So here is the same result compared with mammography. 769 patients, you see the orange bar. Wherever we were 100%, mammography actually missed many, many cancers. It was 67%. And the specificity was actually almost equal, right? Maybe slightly higher in our case, right? Or maybe something like 92%. And this, yeah, slightly higher, 80 and 85, 80.5. But what is also you know, astonishing is that mammography could only take 400 out of 769 patients because the other 250 patients were a younger group or dense or whatever. The radiologist did not recommend you know, mammogram. They directly went to ultrasound. So this comparison is again with biopsy results or mammo plus ultrasound, you know, validated result. And this was conducted in 3 hospitals, HCG, Narayana Hrudayalaya, and another diagnostic center. So all of this, you know, together formed the data set here. This, again, a subset of this was published in a top tier journal called Journal of Clinical Oncology, and this is available for download. This is only on 470 patients because we are doing another paper, you know, which has been submitted to another top tier journal, and you cannot have overlap of data. So this has 470 patients, and you'll see a similar 100% sensitivity, a similar result even in this. And this is one of the top tier journals, the top tier papers that, you know, we'll be happy to share with each one of you to see. There are several such papers we have published. You know, the latest one, which I mentioned, is the Global Breast Cancer Conference, where we look at axillary lymph node metastasis, as well as San Antonio Breast Cancer Conference. You will see a hat trick 2020, 2019, and 2018 as well. So we have continuous 3 posters in San Antonio Breast Cancer Conference, which is one of the largest breast cancer conferences, where I had an opportunity to meet the one who invented chemotherapy and such 7,500 oncologists who come there. We also have AI conference publications because our artificial intelligence, computer science algorithms are also very novel. We have 10+ publications there. And I would like to play a small video where Dr. Kiran Madhamja Shah ma'am, who is also my mentor, talks.
But today we have a new solution which is being provided by a very exciting young startup called Nirmai, who actually have come up with a thermoprofiling technology which actually creates a heat map of tissue and thereby detects the smallest of lesions in breast cancer. And this, I think, is a very exciting time because these are non-intrusive and painless kind of interventions for breast screening. And I encourage every young girl over the age of 25 to start doing annual checkups using these kind of technologies. I think Niramai has a huge potential because I think breast screening and annual breast checkups are going to be very important going forward. But today,
So yes, our advisors and partners, we have, of course, Dr. Amprakash sir, who is our mentor, a guru as well for this. Without him, we couldn't have done this at all. Dr. Kiran ma'am, and also international experts, and Dr. Sudhakar sir from HCG, and also from, marketing perspective from Philips and GE as well. We do have clearances from government bodies in India. Definitely, DCGI is a CDSU organization, and this is NHM Maharashtra. This is Bangalore, which is in Canada, but this is from BBMP. We actually have permission to do it in every government hospital in Bangalore, and we had adopted about 28 of them to do this test. Because of COVID, we have stopped those because those have been converted into COVID screening and now vaccination, and after that we will resume there. But yes, it is still happening in Maharashtra government hospitals, in addition to 75 other hospitals in Apollo clinics, I mentioned HCG, and several. In 15 cities, we have our established centers today. And then in international use perspective, we are ISO 13485 cleared. CE mark audit is completed from German notified body. We expect the certificate to come anytime now, like next week. And then MDSAP for many other countries, we are internationally cleared as well. So overall, the regulatory clearances are multiple here. In addition to the clearances I mentioned, the camera that we use, the thermal imaging device we used, is also certified by US FDA to be safe, CE, and as well as most of the reports that we do in the hospital will go through experts such as Dr. Ramprakash sir to review before actually it goes to your patient. So that way, it's a very, very safe test. It can be provided to women today. And again, just to make sure that all of you know what this feeling of doing the test is, our team has announced a free home screening. That is because it can be done at home. This test can be done at home. Home screening to all of the attendees here, assuming they are all ladies, and so that you can see how the test works at your home or at your clinic, and of course, this is limited time offer. So I will work with Dr. Pallavi ma'am to try and provide you those coupons, which you can just, our team will come to your home or clinic and then do the test for you. And you can see how you can offer the same to your customers. And there are also medical sort of institutions who have endorsed this, like Karnataka Karnataka Cancer Society, sorry. We are in Bangalore. So for the last 3 years, we have been working with Karnataka Cancer Society to do all of their rural camps, right? They do it actually. We have the solution provided to them, and they actually do only breast cancer screening with Niramai test since last 3 years. Same thing I mentioned about Bangalore hospitals, JJMC, many medical colleges. Dr. Balu sir is a huge patron for us as well. And then testimonials from corporate camps as well as women who have taken this test. It's amazing experience and so on and so forth is what they say. And our ecosystem has been very kind. We've received a lot of awards. In fact, I had an opportunity to meet Bill Gates, who is the founder of no, he doesn't need introduction. I met him and I was able to shake hands with him before Corona, because of these kinds of innovation. Finally, from an AI and artificial intelligence and computer science perspective, this is a world map of AI startups. And if you see that India is blue because of Niramai, India is the only Indian startup which is listed on the top 100 AI startups in the world. With this, I really call out for collaboration with each one of you. Please help us save many, many lives, using artificial intelligence and thermal imaging. We can actually detect early stage breast cancer in a non-invasive, non-contact, privacy-aware manner, and also making it so accurate to everybody. And finally, definitely in an affordable and accessible manner so that more women can come and get benefited through you all. With this call, I really open up for Q&A and request Dr. Ramprakash sir to make his comments, as well as Dr. Pallavi ma'am to guide us in any other manner.
Thank you, Dr. Geeta. It was a wonderful experience. Well, many things about Geeta I did not know till I heard it from Pallavi, because she has not told me many things. Okay. Now, as far as thermal imaging is concerned, this is a screening tool. And all of you will remember that breast cancer is on the rise today. And we are seeing it in younger and younger patients. And if we've got to identify these younger patients at the right point of time, we have no other examination that can give us this information other than thermal imaging. And between my own interpretation and thermolytics, there's been a world of a difference, because it has been able to identify or eliminate the false positives that we had given as positives. So that is the one advantage we have had with this coming in. And second important thing is, this can be taken up in a mass scale, where hundreds and thousands of patients can be taken up on a mass scale, which you cannot do with mammography at all. See, for mammography, you require a trained technician, a proper image to be obtained. If the image is improper, you've got to repeat it. So all these procedures get eliminated when we go into thermal imaging. So this, I think, is what the world is going to see in future. And comparing it with PET scan, as far as breast is concerned, it is as good or probably a shade better than PET scan as far as the breast is concerned. Now, you might ask me the next question, why do you say that? Because deeper structures are not very well depicted on surface thermal images. So that is the only drawback we have with thermal imaging as compared to PET, because PET can be used for almost all metastatic diseases. Whereas this is exclusively useful for breast, for the simple reason that breast is a part of the skin. It's a part of the skin, and any changes in the skin that occur can be very well identified. The next point that I would like to state is that it takes about 10 years for a cancer to be palpable. And thermal imaging picks it up at the third year itself, second or the third year of development of cancer itself. Whereas mammography picks it up at the 6th year. And it is at the 10th year that you feel the lump in the breast. So this is the time gap that is there. Just imagine if you were to pick up the disease 6 years in advance, that means you are only doing a lumpectomy. A simple lumpectomy is what will be required, right? Nothing else will be required. And that will be a 100% cure. You will not require chemotherapy. You will not require radiation therapy. Nothing will be required. So that is the advantage we have with thermal imaging today. And I think in the near future, it's going to become one of the most important tools, which is going to be used not only in breast cancer, in quite a number of other diseases also. It is useful in sports medicine. It's useful in diabetics. So these are other areas which need to be incorporated into thermal processes. Okay, so that we are ready to take any questions that you might want to ask any of the participants. Thank you, Geeta, once again. It was a wonderful presentation.
Thank you, sir.
Thank you, sir. Absolutely a very wonderful session. The concept itself with the highest specificity and sensitivity, with the ease of use and also the portability. I think that would score over and put it, it will go in a very long-term scenario, right? Yes. So I think the audiences must have gathered well the concept. It's absolutely not difficult at all. I would like to have few questions. Now, when a patient is posted for mammography, like for a general screening, normally what the general gynecologist or the surgeons or the oncosurgeons, we put a history that it is always preferable that you do it post-menstrually, because pre-menstrually the patient has a lot of congestion in the breast due to the hormonal changes because of the water retention due to progesterone. So are we having any prerequisite, any relation to the menstruation?
Yeah.
If I want to answer that?
Yes. So generally what we do is for the analysis itself, we take the last menstrual period, LMP, as one of the inputs itself. Yeah. So we look at the the scan date and the LMP and try to utilize, compute what phase of the menstrual cycle the person is before doing this.
Yeah.
But this is only true for camps. But when you're giving appointments, we generally say like 5 days after, during the
Post-menstrual.
we try to avoid
So
it.
yeah.
Yeah, but in a camp setting, it is fine. In fact, we are doing a trial, ma'am, a separate study where we have actually made about 10 women go through Niramai test continuously for 6 weeks, every week, right? So the cycle is coming. So we are going to come up with a guidance and doing the adjustment.
So the more fine tunings on the
menstruation, but it's a very good point actually.
Your so binary line of 0 and 1. Yeah, that's
yes,
fine.
Yes.
Yeah. Second thing is now since this is temperature interpretation of the thermal spots, the hot nodules and the cold nodules. So I think the patient has to be afebrile.
Sorry.
The patient has to be afebrile.
Correct.
Yeah.
Correct.
So somewhere between 35 to 37, that's the normal body temperature would be the ideal candidates, right? This is like just general information I'm trying to, so that we know clinically, because then what are the patient selection? So the patient selection criteria and the landing instructions to the patients to refer for the test should be, complete. And then third question is,
I think, sir, you can correct me. Even patients with fibroids can come in for the test.
Yeah.
There is asymmetry. And, of course, we have not done a complete trial.
No. My
question was about fever.
My question was, supposingly, you do take the temperature records. So, but if the patient is having fever, 101 degrees.
Okay, sure.
So then that day the patient is out, right?
Yeah, that is true. But still asymmetry will show up. But generally, yes, a person with fever.
It's better not to, it's better not to do on that day. Yeah. And any, supposingly, I'm talking about not obese. Most of the Indian ladies, 45 plus, tend, because of those hormonal changes and perimenopausal, they start putting on weight and everything. But what about a very, very heavy breast?
Not a problem.
I mean, not really, not a problem, right?
Not a problem at all.
Yeah, okay.
Any size of the breast is not a problem, because the entire breast is a skin appendage. So it makes no difference whatsoever as far as thermal imaging is concerned.
So the penetration is not at all affected.
No.
And just to add to sir, we make the person sit like this, right? So sometimes what happens, the inframammary fold, does not get captured. So we make the person sit and straighten up. So we try to
just extend. So just extend it.
So that is needed. Apart from that, otherwise the sagging a little bit, we lose the underthing.
Yeah. So
like sir said, because it's on the skin, we actually also do vascular analysis. When you do the vascular analysis, even if the lesion is very deep and she has very big breasts, right? The blood vessel structures are under the skin only. So you will see it feeding into it. So you will see an asymmetry in but the exact location, it will be difficult to find. Then that's why ultrasound is
okay. Any absolute contraindication?
There is no absolute contraindication.
That's a very clinical,
There's an absolute indication. Let me tell you about the absolute indication. Now, today, we know definitely that there's a family history of malignancy.
Yeah.
Right? It tends to go on in families. So we should start a thermal imaging at age 25. When we do a thermal imaging at age 25, we categorize them into certain categories. Now, not everybody has the same sort of a breast response to the menstrual cycle. I'm sure all of you are aware of that.
Yeah.
Why is this difference between one lady and another lady? It is mainly dependent on the hormone receptors or the quantum of hormone receptors that are there in the breast. So it is important for us to identify such of those who have a larger quantum of breast receptors in the breast. Because if a cancer develops in them, the progression of cancer will be very, very rapid as when compared to one who has less number of hormone receptors. That is the variation that you get in the progression of the disease. So in that context, starting at an early age for families that have a breast malignancy history is very, very ideal and important. So this one area where I think thermal imaging plays a very, very extraordinary contribution.
Second could be like, I mean, just a practical, if we try to segregate the patients or from the history where there is unopposed estrogen, like in all the nulligravid patients, right? There is
Correct.
no break to that unopposed estrogen because they had never been pregnant.
Yes.
So those could be the candidates whom it can be started at a bit earlier age.
Correct.
Right?
Yeah, absolutely. Yeah, so like we said, sometimes pregnant women who are lactating also show up with vascularity and high thermal signature. But it is not harmful at all. You can still conduct this test for pregnant ladies. Of course, the chances of malignancy in pregnant ladies is only 1 in 1,000. Still, we have found with a very, very top OBG clinic chain, right? We work with them to actually do just 150 pregnant people. And I know many of you are gynecs here, and I would like to share one more related point here is that the abnormality or malignancy in pregnant ladies, or asking a pregnant lady to say check for cancer, is like very disturbing for her. However, what we have found is when we do the analysis and thermal imaging of pregnant ladies, we are able to give additional guidance, not just cancer. Of course, if there's an abnormality, we may be able to find. We do not give a score. We work with the gynec to give the right guideline to her, but we are able to determine the lactation capability of the person. So, for example, we have done a person for screening, thermal screening every trimester, and you will see that there is an increased vascularity. The vascular score increases, right, over trimester. And secondly, as you know, I don't have to at all tell you, but there is a difference in lactation capability between the left side and the right side. And whether it's left or right is producing more milk depends on the person. Mostly, I think it'll be left, but it depends on the person which breast to use for feeding more to the baby. And this, the lactation guidance can be given by just taking a snapshot on these scores that are generated by Niramai. This is what we call as a mother care product, just for new mothers, and also maybe like every trimester you can see, because if there is some part which is not like blocked or something, we can actually notice it over the trimesters also. The only thing is we have not done a full-fledged trial on this. About 150 pregnant women we have screened, and we have seen this difference. We have done an oral confirmation saying, okay, after the baby was born, did you actually use more, did you get more milk in the left, because the analysis is showing, and all of those cases have matched actually. So this is a gynec community. I'm very excited.
Retrograde, yeah.
Be part of this, multi-site trial on just pregnant women for providing lactation guidance, nothing to do with cancer, just breast health, right? That is also a completely new segment and new product that all of us can actually create for women.
Thank you, madam. Thank you for elaborating it very nicely.
Can I say something, please?
Yes, ma'am. Yeah. Yes, sir.
When we started with ultrasound, we did not realize that gynecologists and obstetricians would get ultrasound machines into their clinics. Because in India, females generally go to a gynecologist for their breast problems. They don't come to a surgeon, or they don't go to a physician. Very rarely they go to physicians and surgeons. They generally come to obstetricians first.
Yeah, sometimes, sir, when you identify, or if their mammography report is positive for malignancy, it becomes really very difficult. They will say that you operate. I said, see, it's not Correct. In my purview. You should see an oncosurgeon. I mean, it becomes so, because of femininity, they try to identify it with the gynecologist. No. So I think most of
what I'm trying to say is yes, that all of you have come into ultrasound. Now all of you must come into thermolytics also. Because automatically, apart from examining the genital organs, this is also part of that. So this also could become a very important add-on, because the cost of the machine is equal to or smaller than the cost of a good ultrasound machine today.
Yes.
Unlike a mammography machine, which is today 1 crore rupees.
Yeah.
So no, actually, very good point that Dr. Amprakash sir brought in. I think, and just I would like to interject, what are the options available for the gynecs, if it's okay, sir, if I can say.
Yeah, please go ahead. Please go ahead.
So, See, today, all of you are gynecologists and you want to, let's say, provide thermolytic solution. And we have Kamal and Surajit from our business team, but I'll just share two models which are available, which may be useful for you. The first model is, like Sir said, it's not a very expensive equipment. You can provide this, just like you're providing your ultrasound for the end user, you can provide this. And your ultrasound also is going to be faster if you do this thermal imaging, because we have the location identified. I didn't stress too much about it. The location is identified just like a mammo would have identified location, in the sense that in the image, which quadrant, which clock position it is. And that is where you can focus your ultrasound on. So that is point number one. Let's say you don't have too many patients walking in. It's a small clinic. You mostly spend time in the hospital where you have, big machine and you are buying a thermolytics there. Then our team actually has a direct to doctor model where you can just say, I will provide niramide thermolytics test only once a week. Let's say every Monday, whoever wants to get a breast screening, come only on Mondays. So then also, without buying the machine, our team will come in and provide that test for you on a weekly basis. And then that will be much more economical for you. And you will be providing for your patients also. It depends on how much crowd you have in the clinic, right? So basis that you could also take, and also you can do like camps on some of these days, maybe every Friday. You can't say Women's Day. I feel Women's Day has to be celebrated every day. But anyway, so this is just a small bit of information. More information is provided by Kamal and Surajit who are here.
Yeah, fine. Ram sir, can we have the closing remarks from your end?
Yes, after going through all this, I started mammography in Bangalore. In Karnataka, I should say, I was the first to start mammography. I was the first to start ultrasound in Karnataka, right? I was the first to start endovaginal ultrasound. And I happened to be the first to start the thermal imaging in India. But I would love to see more and more people getting involved in thermal imaging, because that is the future of breast diseases, not only breast cancer, for all breast diseases. Just now, Geeta was narrating about lactation. That's another area where I'm sure you will be very interested in. So these are some of the areas where we can provide a quality output at a very low cost. So that is the advantage we have with thermolytics today. So I'm sure all of you would definitely open up your minds to conceive the idea of thinking about this on a regular basis.
Yeah.
Thank you. Thank you very much.
Thank you. Thank you very much. I would like to thank from the bottom of the heart to Dr. Geeta Manjunath, Dr. Ram Prakash sir, sparing very valuable time on weekend, on Sunday. But we selected this date because tomorrow we are celebrating International Women's Day. So I thought this was a very good occasion to launch the concept in Baroda and Gujarat. So I would also like to thank Kamal, who had helped me outright in coordinating the entire thing. And I think, Kamal, few of the doctors will keep bothering you now and then. Yes, for more technical inquiries or whatever. So I will be sharing your number further. I would also like to thank Dr. Meenakshi Patel for giving her presence and blessings to the program and CME. And I would also like to thank all the participants today. Kamal, I think you can just take the list, or in case if I have some queries, and if anyone wants to have a home screening out of the participants today, so I will provide you with the list and then you can coordinate in one go then for everybody.
Sure.
Thank you very much from, again, bottom of my heart, Dr. Pallavi ma'am and Dr. Meenakshi ma'am. I think it was an excellent session. Thanks for bringing all the gynecologists together. I know yesterday I was there and she was in another seminar, it's an amazing service.
That's okay.
And really look forward to partnering with you in multiple such, endeavors. Thank you so much.
Thank you.
Thank you, ma'am. Thank you.
Thank you, sir.
Always been a great guru. Thank you.